clinical applicator for Mindray and Cairo Medical, and the organizer of the talking for this first. We have the engineer Andy. Where is engineer Andy? Mr. Andy. He is Mindray marketing manager for Africa and Middle East. Thank you. Very good afternoon. Yeah, we are a little bit late, but anyway, it's very happy to see everybody here. My name is Andy Sant. I'm in charge of Mindray ultrasound marketing in Middle East and Africa. So for me, it's a great pleasure to see you guys here. As I've got information from our partner here, today is a very special event. It's like a big party for our doctors, because I know that most of you doctors here are our current Mindray users. So I'm truly happy to meet you doctors here today. And for this year, I'm also very happy to take this pleasure to invite Dr. Jeanty to come here to Egypt. Dr. Jeanty has been a friend of Mindray for a few years already, and we like him very much, and it's also our great honor to have him give us a solid support over the last few years. So thank you very much, Dr. Jeanty. Okay, so firstly, please allow me to introduce our speakers for today. Philippe Jeanty is our gynae doctor from the United States. He's been involved in this area for more than 35 years, I think. And he has authored a few books. I think many of you have maybe read through the books already. So no need for me to introduce more. He's the director of the ultrasound section, Inner Vision Women's Ultrasound in the United States. And also today we have Professor Mohamed Kamal from Asian University Hospital, who is also a friend of Mindray. And again, we have Professor Yehia Wafa, the head of the OB/GYN department of our Azhar University Hospital. Thank you very much for coming today. Right. As we are here in Egypt, and I would like to show a few information to our doctors about Mindray achievement over the last few years. Actually, Mindray entered into Egypt since 2004, and over the last 10 years, we have made some great achievement. The total number of the installation here in Egypt, we have more than 12,000 units. I think that's going to be even bigger and bigger in future. And also we have the market share, let's say, coming from last year, 2014, we are already number one, in this market. We have, in terms of sales volume, we have 30% of market share in Egypt. And if you look at the installation base, total number of units we have installed in Egypt, we have more than 50% market share already, which is really a big achievement. And I would like to take the chance to thank you again for being our customers. So all of these, we have done in the past, make our brand name here more famous, let's say. And we would like to emphasize on this sentence, healthcare within reach, because this is our dream. And we believe that every single patient should be equal. Doesn't matter poor or rich, doesn't matter white or black. Yeah, they should, deserve the right to enjoy the best healthcare services in this world. So this is what Mindray believes and what we are doing for the future. So I'll give you a few information about Mindray. We are a young company, actually. We are more than 4 years old, and we are established in 1991 and based in Shenzhen, which is very young, energetic, but also a big city in China. And globally, we have more than 10,000 employees, which is also growing, very rapidly in the next 2 years. And also we have 11 R&D centers globally. 4 of them are from United States. And we have 31 branch offices all over the world. So that means you can enjoy our services, across the whole world. And also in Egypt we have the local office, and which was established I think 4 or 5 years ago. And we are not a private company now, we are a public company. You can see our financial performance at any time you want. And also we have been exporting to 190 countries with our products. So that's a brief introduction. And looking at the sales performance, we are really growing very fast. In 2007, we have something like $300 million sales globally. And now come to the last year, we have 1,300 million, 1.3 billion, which is not double or triple, which is 4 times bigger than 7 years ago. So this is, not every single company can do in the last 7 years, and we are one of the few who can do this. And we have now 3 main product segmentations, which are patient monitors, life support products, in vitro diagnostic, and also medical imaging systems, which includes Mindray ultrasound and also radiology products. And looking at the ultrasound segmentation, we have really a full range of ultrasound covering from the low end to high end, from black and white to color Doppler, from card-based to laptop. So that means we can cover a variety of the needs from the market, from general imaging, OB/GYN, cardiology, to the emerging market, POC market like anesthesia machine, anesthesia, emergency ICU, and so on. And here is a picture that you can find Mindray all over the world. With the red dots, we have the R&D centers, and the blue dots, we have the subsidiaries. And here we are here today in Cairo, and we have the local office here. All right, just 1 second. You may wonder how Mindray performs in each segmentation. Here are a few figures. For patient monitors, we are top 3 providers in patient monitoring, and we are number 3 in anesthesia machine segmentation. For hematology analyzer, we are globally number 1 in installation base. And for the ultrasound, we are number 1 for the low end to middle range ultrasound globally. And for the laptop color Doppler, for this small segmentation, which is growing very fast, we are number 3 globally. And this great performance was due to the huge investment into R&D. Mindray now every year invests 10% of sales revenue into R&D. If you calculate this number, last year we have 1.3 billion, and 10% of that, which is $130 million, was invested into R&D last year. And nearly 2,000 employees in Mindray are working in this, new technology, new product development every day. And this is more amazing. 65% of these 2,000 people are with either master or PhD degree. So that means really good talents, are working for, developing these technologies. And every year we came out with 7 to 12 products, and more than 2,000 patents we have, developed now in Mindray. Right, here are the R&D centers we have. 4 of them are based in US, 1 from Europe, and 7 or 6 from China. And for Mindray ultrasound, we have 2 R&D centers, one from Silicon Valley and the other one from Seattle, and another 2 from China, Beijing and Shenzhen. I've got 5 minutes. I'm trying to speed up. Okay, and 2 years back, we acquired a company called Zonari, which is one of the leading ultrasound providers in the United States. And with that, we're going to get into a high-end market in the future. And very quickly, you may wonder the new machine here on the front, and I would like to give a brief introduction. It is a newly coming out ultrasound machine from Mindray, and stands for the latest technology. And basically, it has 19-inch monitor, 10.4 touchscreen, and also some ergonomic design like the control panel and so on. And we have now, because of the compact design, we have very lightweight, 85 kilogram, and you have the gel warmers, USB port, even dedicated TV transducer holder, which makes the machine very easy to use. Right, I want to go through this briefly. I have only 5 minutes. Okay, so very quickly, in terms of the OB guiding part, we have a few good features that I want to show you. For transducer, we have 7 probes covering from the very often used application to like the 4D vaginal probe. And also we have some very smart functions like Smart OB, we call it Smart OB, Smart NT, Smart B. And again, we have some special function on the 3D 4D. So here, iLife, this is actually a very revolutionary, unique function on DC-70, which gives the a very amazingly realistic view of the fetus, also with a human-like skin. And also, moreover, you have a light sourcing from different directions. You can put, wherever you want to give a real lighting on the fetus face. And again, we have this Smart OB, which is a automatic measurement tool for those very often measured parameters like BPD, HC, FL, AC, and so on. And this is a very efficient, accurate tool that will save you a lot of time. With a single click, you can get a RQ calculation on all of these measurements. And we have some other analysis tools based on the 3D 4D data. And here with the endocavity 4D probe, you can have a free view over the the scanning angle. And this is some very unique. This is actually the first touch, let's say we call it gesture sensitive touch screen. You can do really a lot of things on it. And I'm going to show you a quick video here. Right? You can shift the image from the big monitor to the smaller one. Anyway, I think it's better to try it by yourself. The video doesn't work here. Anyway, I'm sorry, but it was working. Okay, and moreover, for the doctors, you have very dedicated functions like MedTouch. This is a function that you can download on your smartphones or your smart pad. You can control the parameters by these external devices. For example, the gain depth, iZoom. This is particularly essential when you are away from the machine, for example in the operation room. And also you can review, query, and retrieve the patient data by using this software. Here are some pictures. And again, some patients, for example, the pregnant woman, they want to see their babies, they can also get this software website downloaded on their phone, so they can get the image immediately after 3D, 4D pictures have been made. So you can transfer the image directly to their phones. So the patient will be more than happy to receive all of these pictures from from the ultrasound machines directly. So this is also an additional benefit you can give to the patient. All right, okay, I think I'm almost finished. And now, should I invite?
Thank you, everybody, and we thank Andy and Dr. Philippe. Jeanty is going to be now with our headquarter engineer Yehia to open the machine.
Okay. You want me to present from here?
No, not presenting, opening the machine with engineer Yehia. And wow, can I have some picture? Thank you. And we're thanking Engineer Yehia and Dr. Philippe Jeanty. We will have something. You're gonna talk about your lecture now?
Yes.
Yes? Yes, right now. Excuse me.
Well, maybe we can just put the cable here.
The cable in
Oh,
here?
you want me to move over there?
Yes,
Okay.
if you want.
Yeah,
Maybe you can bring the chair for you.
Yeah, that's perfect. Let me do that. Yeah, the next one. What is the resolution of the projector? Okay. Good afternoon. Thank you very much for letting me come over here. Unfortunately, I think there's a little conflict between the resolution of the projector and the laptop, so some part of the image seems to be outside of the screen. Let me see if I can fix this for a second. consists of beautiful diagnoses from everyone, and when I would go back to my practice and I would try to make those diagnoses, I had terrible results. So I wanted to learn what was the reason and what were the errors that you could have. So one learns from other people mistakes, so I have to beat these other people. So for instance, you would not sit on the chair because there's a thumb tag on it, but not only there's a thumb tag, there's also a broken leg behind the chair, so be careful for this kind of crime. This is an example from many years ago. One of my residents was looking at the fetus when he was on call, and he found some cord cysts, many cysts in the cord, and he took 68 pictures of the cysts in the cord. That was very well documented, but at the end of the cord, there was a baby with trisomy 13, and he did not make the diagnosis of trisomy 13. So very often, we find something, we get attracted to that issue, and then we forget to look at the rest of the baby. This is a baby that I thought had acrania. I told the mother the baby has acrania. Actually, the baby did not have acrania. It had amniotic band disruption, and the baby had this big cleft over here. Now, this was a big shock for the mother to see that. And how does this happen? Well, when the amnion rupture, the baby can swallow the amnion, and at some point, it gets stuck at the cord insertion here, and when you get to this level, it has no way to move anymore, and then the amnion disruption starts cutting through the baby's brain. So that was one big mistake in this baby. And the second big mistake was that the baby also would not deliver. There was actually twins. The first twin delivered, and the second twin does not come out. Why is the second twin not coming out? Well, what do you think about the membrane in between those twins? Normal membrane, thick membrane, very thick membrane. This was a didelphic uterus, and these were pregnancy in both horns. So I missed the amniotic band syndrome. I missed the fact that it was didelphic, and so it caused a lot of problems. So pay attention to the exam that you're doing. This is an even worse issue. This is a baby. One of my sonographers was scanning it, and she has almost finished the exam, but she has a phone call, and she has to take the phone call from her daughter at school or something. So she said, Philippe, can you measure the femur and the humerus? I have everything else. So I measure the femur, I measure the humerus, and I let the patient go. And then the referring obstetrician says, Philippe, you know, this pregnancy is very big. Are you sure they're not twin? How can I do? It's great.
خلي الصوت زي ما هو بص خلي الصوت زي ما هو
No way. So the patient comes back, I put the transducer, and on the same image are both heads. So I had missed a complete 17-week fetus. How does this happen? It happens because I did not pay attention. I did not do my complete routine, up and down, left and right. And so the big lesson there is don't do an incomplete exam. There will be many temptations to go faster and cut corner. Don't do that. So let me show some errors due to the equipment. And this is a problem that happens when you have a big motor starting an elevator or big machines or couturization for cervical couturization in a room close to you. It causes some electrical interference, and sometimes those are bad enough that you can't see anything. It's another example where the image is completely destroyed by electrical interference. Here you can see on this tracing a line that does not belong to the image. Same problem. This is a patient that has in vitro fertilization. She's very anxious to see the baby's heart, and she sees this line here on the screen, and she's very happy to see the baby's heart. That is clearly another heart. The heartbeat is over here. Same thing, electric interference. This is in the old days. We had films in the old days, not digital, and when the film was put in the cassette, and there was some static electricity in the winter when it was very dry, then dust would be caught and would do the same dots. Same thing here. This was one of my sonographers brushing her hair as she was putting the films together, and her hair got statically connected to the film. What is happening here? What is that? This is a broken transducer. Transducer are very delicate equipment, and if you let the transducer drop on the floor, then the elements here are no longer attached, and they create a shadow like this. And that shadow is very typical because you will see the same shadow from image to image. So you do one patient, you do the second patient, the shadow remains in the same place. So be careful with the transducer, always reattach them where they're supposed to be. Other example, you see the same shadow no matter where I put the baby. These are issue of focal zone calibration. Now, as digital machines are improving, you don't have this anymore. But in the old days, sometimes you had the gain for default focal zone were not set properly, and then you would have those shadows in the middle of the image. Improper calibration, this used to be something that happens in the old days, that you would measure a landmark on the fetus, and actually the measurement was not correct. And I thought, well, this is an artifact that we're not going to see anymore because now with digital machine, we don't have that problem. But that artifact came again because now when you have picture archiving systems, PAC systems, the calculation on the screen of the PAC system may not be the same calculation as the screen of the ultrasound machine, and then you have errors in the measurement. So when you open an image on the PAC system, make sure that you measure the graticule alongside the image so that you confirm that this is indeed the correct measurement, otherwise you may make erroneous reports. Gas station unit, you have seen this. Here we're predicting the size of the pregnancy to the 100th of a week. The 100th of a week means you're predicting when the baby was made within 100 minutes of precision. This is ridiculous, of course. 25.7 is good enough. We should not have more than that. Some physical artifacts. Reverberation artifact happens here. You have a beam that goes from the transducer to a structure and reverberates and return to the transducer, and that makes the image that you expect on the screen. Now, some of the beam may have enough intensity that they bounce back on the transducer and come for a second time. And when they come for a second time, they do the same trouble, now with a attenuated strength, come back. I'm sorry? Even closer? Okay. Okay. If you can't hear, you have to complain, okay? And now the second beam creates an image identical to the first one, but most posterior. And this is an artifact that happens quite commonly. Here, this is a woman, you can see the bladder. She has an ovarian cyst, and here you see this big area behind the bladder. And this was initially reported as being a cyst. This is actually the vagina. There's some air in the vagina, and behind the air has made an acoustic shadow, so there's nothing visible, and there's a reverberation artifact that goes the back of the image. So this complete image here does not exist. Here's another example. This is a baby's head, and you see another image behind it here. That image does not exist. It's a reverberation artifact from the head. This is a woman, a postmenopausal woman with a 7-centimeter cyst, and it had some irregular borders, so it was considered to be not a simple cyst. Because of that, they asked to have surgery on this patient, and by some fortunate event, this patient was rescanned just before the surgery, and the cyst had completely disappeared. Another reverberation artifact, so be careful about those artifacts. Here we have the uterus, and we have an image of online radius, another image here. This actually is not a reverberation artifact. This is a calcified yolk sac, and you know, calcified yolk sac has an association with an epiloidy. Side lobe artifact, when we use the beam, we have a tendency to think that the beam is just pencil thin, and it just does one line at a time. And that's not completely correct, because alongside the beam, you may have some side lobe beams, which are slightly deviated to the side, and the intensity of the side lobe beams is not very high, maybe 1%, 2%. And so usually, if you add 1% gray or 2% gray to the image, it doesn't make a difference. But there are some situations where it does make a difference. For instance, if you look at the bladder, adding 1 or 2% gray over the black of the bladder makes a difference. And a long time ago, many of these patients have been referred for having urinary tract infection or debris or pus in the bladder. This was absolutely incorrect. This did not exist. Edge shadowing, this is actually an artifact that we use. At the edge, when the beam is tangential to a curving structure like this, there is some issue of reflection, refraction, and phase cancellation. So the beam go up and down, and there's some phase cancellation, and that gives a shadow that tells you this is the edge of the round structure. So this is an artifact that we use. And for instance, here you can see that it would appear that this patient's bladder is in direct continuity with the emetic fluid of this baby. Of course not. This is just an edge shadowing here that makes this area disappear. Do you know another place in the exam where this was a problem? Ventricoseptal defect. If you look at the septum in that angle, you may have the impression there's a ventricoseptal defect when there's actually nothing. So you see, it can be some quite big defect. Mirror image. Here we have the transducer and the beam, and it hits a reflector, but the reflector is not perpendicular to the beam. So the reflector sends another beam to somewhere else in the body. And here it sends to this green screen here. So the machine get the yellow echo come from the red interface, puts it in the right place. But then the beam that has gone to the green and then back to the red and back to the transducer is placed as a second dot on the machine, on the screen. Now the machine doesn't know that the beam has been deflected to the side like this. The machine simply supposes that the beam comes deeper inside the patient and places the image deeper. And that causes some artifact like this one here. Fortunately, the image is a bit off from the screen, but you see her uterus, you see an ovary with a follicle, and there behind is a second ovary with another follicle. That second ovary does not exist at all. It is simply a mirror image created by the machine. Sometimes you can have this in a much worse situation called a double reflector. Now the beam goes on the first reflector, and instead of coming back, part of it goes to a second reflector, and from the second reflector, not for the first, but directly to the transducer. Now that beam arrived with some delay, and the machine places it deeper. And here's an example of a fetus in which there is a big echo inside the head that was originally thought to be a tumor, and actually does not exist at all. The machine has completely invented some image over the baby's head. By the way, Andy, don't get worried, this was not a Mindray machine, it was a different machine that was inventing that. A specular reflector is a reflector that is just perpendicular to the beam. So here, the fetus is exactly perpendicular to the beam, and because of that, the intensity of the reflection is greater. It's like looking at the flashlight in a mirror. If you point the flashlight straight at the mirror, you have a big, bright returning light. If you point it at an angle, most of the light goes somewhere else in the room. So this is something that happens, and you have image like this one, where you see a big white dot here. That big white dot is not a section for a rib or anything else. It is simply the specular reflector, and when you turn around, you can see that it turns as the baby is moving. So it's always the surface that is perpendicular that will give this reflection. Same thing here, you see this baby looks like it has some food in the stomach, and when you move the angle so you don't have a specular reflector anymore, that image disappears. The rectus muscle artifact is an interesting artifact. You know they have rectus muscle, and they have an ovoid shape if you make the cross section for the ovoid here. So the beam that goes for the main portion of the rectus muscle goes straight and comes back and produce a normal image. But when the beam is angled and it goes slightly to the edge, it goes into this lens shape form of the rectus muscle, and because of that it deflects and it turns the beam. So instead of having just a normal image, you have a second image next to it. And this is what is happening in women that have very strong abdominal muscle, women that are doing a lot of jogging, swimming, things like that. And this is an image here. This has been sent to me as conjoint twin, and they wanted to have a termination of pregnancy because of conjoint twin. And actually, that patient had absolutely normal twins, normal singleton. This image was completely created. This is another example. You see one skull. This one had been referred with suspicion of subpedicele, and here the same thing, an image with a double skull. So be careful, and the way to avoid that is to rotate the transducer and look at the same area from a different part of the abdomen, because then you go for a different part of the muscle and you don't have this artifact. This is another young woman, and you can see she has an aorta and supramesenteric artery, and right next to that aorta is a second aorta with a second supramesenteric artery. So this artifact can happen anywhere in the body, and be on the lookout to recognize that. A pool reflector is a reflector that is actually just the opposite of the specular reflector, which is aligned with the beam. When it's aligned with the beam, there's nothing to reflect anything, and so the beam doesn't return. If the beam doesn't return, the machine has nothing to write on the screen, and then you have a black spot. Here, on the other hand, when we turn the ventricle, we have a good reflector and we can see it well. Now, if there was truly a ventricular septal defect here, there would be a crest at the top of the defect, and then that crest will return a small echo. So be careful to recognize a tiny white dot at the onset of a black space being a true ventricular septal defect. And this is this tiny white dot. You see this white dot here corresponding to the ventricular septal defect. This is maybe a trisomy 21 and an atrioventricular septal defect. Volume averaging, if the beam thickness is the same thickness as the object you're looking at, then you have a normal image. Here we have the stomach on the screen in the normal presentation. But if the beam is interfacing with the edge of the object, then the edge is represented inside, and you have the impression of those masses that you can often see in hollow structure in the body. Velocity error, the machine calculates the depth of an object by measuring the distance equal speed times time. You see, this is an old image. This landmark does not exist anymore, of course. So if the speed of ultrasound varies in the structure, all of a sudden those calculations are not correct anymore. For instance, if you have fat or if you have liquid, it may make a difference. For instance, here we have a lesion and the speed is different. So look at the diaphragm behind that lesion. It's a hemangioma. You see there is the impression that the diaphragm here is indented, when actually there's nothing wrong at all. It is simply a variation of the speed that kind of fools the machine into making abnormal measurement. Acoustic enhancement, that is a measurement, an artifact we use all the time. The deeper the beam has gone, the more it loses intensity as it comes back. There are more scattering and loss of intensity. So the deeper the distance, the greater the intensity. And in order to compensate this attenuation, the machine has a built-in curve that you can modify, those little sliders you have on the machine, and then you compensate by creating an amplification that compensates for the attenuation. This is a very common issue. Now, if the beam goes through a structure like a cyst here in the middle, and the cyst has no interface, so there's no attenuation for the duration of the beam inside the cyst, then the curve that we have here, which is assumed by the machine, is no longer the true curve, and at this level we have a flat spot. So now we have a flat spot here while the beam was inside the cyst, and then the attenuation goes on as before. Now the machine doesn't know it was a cyst, so the machine keeps amplifying as it would normally have been without the cyst. Because this amplification is not too high for the location, you have an acoustic enhancement behind the cystic structure. And this is the white spot you see behind all the black spots. And that's something we use all the time to recognize whether something is liquid or it is solid. Pulse ambiguity is something that happens in Doppler mostly. Here we have a beam that is sent to an interface, and before the first beam has been sent, a second beam is also sent. So the beam goes to the interface, and before it has time to return, a second beam has been sent. And because of that, the machine creates interface that don't exist. The red one and the yellow one here don't exist. only the green one exists. This is called pulse ambiguity, and you know that you can change this in your machine by changing the pulse repetition frequency or the velocity scale. This is very important when you do field echo, for instance, and if you don't change your pulse repetition frequency, then you're going to have either a flow that is too fast, and then you don't see enough color, or too slow, and then you see color everywhere, and you don't see color inside the cavity. So this is important to adapt on your machine. This is a patient that is 38 years old. She's been trying for 13 years to get pregnant. She has this no fetal heart. So she asked, doctor, is there any other technique? Should we do CT or MRI? And then one of my sons said, well, we could do Doppler. Well, we do Doppler, and we find this. And this is not cardiac activity. This is a scintillation artifact. This happened at the interface between bone and soft tissue. So watch out for the scintillation artifact. This is another example. You see the fetus is dead. You see there's some edema all around the fetus. No cardiac activity in real time. And when you put color Doppler, now all of a sudden you see pulsation. So be careful, because you can recognize this as a scintillation artifact, but most patients have no idea what it is, and they will see the beating and they say, my baby's alive, don't terminate my pregnancy, this is not a miscarriage. If you want a precise image, you need to give the machine the time to build the image. So that includes having many lines and many points on each line. So a pretty image is an image that has many simple points per line, and a precise image is an image that can rapidly and has fewer images. So if I show you this image here, what does it represent? Anyone? Not enough sample point to know. Okay, I add some more sample point, and you see Abraham Lincoln. For some reason, always people use Abraham Lincoln for that. So the image of Abraham Lincoln here requires a lot of points and is precise, but the other image, the one with a few square, transfer very fast. So you have to decide whether you want something precise or whether you want something pretty. And this happens all the time in field echo. If you do a field echo, and the focal zone are placed at many different levels, you will have a smooth looking image, but the area of the heart that are moving rapidly will not be visible. For instance, the valves will not be visible. Errors of measurements, incorrect technique, over and underestimation. Here we have a normal femur. Here we have a femur that is too short because the other femur has shadowed the distal portion of the femur. Sometimes the landmarks are not very clear, so there's a tendency to guess where the landmarks are. I think it's better to say, I just can't take that measurement and guessing it. You can use inconsistent table, inappropriate measurement, or averaging of measurements. Very often, young physicians who start doing ultrasound have a tendency to measure alongside the edge of the image. I don't know why it is, but I think we have a tendency to, one organization or the BPD here was not alongside the image, so you have to be careful for that too. When growth tables have been established, they were established by looking what is a dependent variable size for an independent variable. So for instance, you measure the femur and you want to know what is the size of the baby. So you measure the femur here, and you find that the femur tells you the baby is 20 weeks along. But that same table cannot be used in the other direction. You cannot say, okay, this is a 20-week baby, this femur should measure so and so. That is not correct. And you know that because the interval of confidence are not the same. Here, we have well-defined interval of confidence. In this direction, we don't. So be careful to use the appropriate table. Don't use the same table for answering the questions in both directions. Patient comes at 35 weeks of gestation, and you want to know, she doesn't know her gestation, she comes in third trimester, she wants to know, how far am I, and is the baby big enough? So you measure the BPD, you find the baby is 35 weeks of gestation. Is it appropriate for gestation age? If you measure the BPD, well, of course it's going to be appropriate. You just found out the gestational age was 35 from the BPD. What you have to do is a different approach. You have to measure something that is independent. For instance, the femur tells you the baby is 35, and now you measure the estimated fetal weight, and then you say yes or no. So you have measurements that don't depend onto one another. What do you do when you have unequal measurements? For instance, you have a BPD 41 weeks, head perimeter 42 weeks, femur 35 weeks, humerus 36 weeks. What age is this baby? 35 weeks or 42 weeks or something in between? It could be a 38 weeks that has some high cranial measurements and some low scale measurements, but it could also be a trisomy 21 or a hypochondroplastic baby that is at 41 weeks and with short limbs. So if you see a baby like this, you have to think the different possibilities and resolve those possibilities before you make a decision. How am I doing with time? I'm seeing what
Take your time. Okay.
I'm sorry?
Take your time. Take your time.
No, because I have like an hour and a half.
Don't worry.
Incorrect settings, let me go for some examples here. Where is the placenta? Anterior or posterior? This is too big to be a substantiated placenta. This is just a complete lobe here and a complete lobe there. So what's the answer? Well, the answer is ask the patient what happened. And this is a patient, the physician did not tell us the detail. She had twin, she miscarried a twin at 23 weeks, and this was a placenta that had been left in place. This is a patient, she's Vietnamese, she doesn't speak English, and we think, oh, she has an intrauterine device, an IUD. Well, no, this is not an intrauterine device. This is a patient that had a procedure in the morning, and they left air bubble in her uterus, and now we thought that she had an intrauterine device. So very important to get the clinical story when you do an examination. This, unfortunately, you can't see the whole image, but this is a big, solid mass in a 34-year-old African-American woman. And you know, African-Americans have a lot of fibroids. So, 34-year-old, you find a big mass, you think fibroid. This is not a fibroid, this is a chondrosarcoma of the iliac wing. So if you just go for the most statistically common diagnosis, you can miss this kind of problem. This is another very interesting pitfall. This is a gynecologist who sent a patient and says, on my exam, I find something in the right anexa. Can you check? So we check her uterus, we check her anexa, everything is perfectly normal. And the sonographer, for unknown reason, go and check her kidney. And in her kidney, she has a renal mass. So the gynecologist originally had seen the renal mass, but he's not used to talk about renal mass, so he said anexa. So he give us the wrong information, and my sonographer, for some unknown reason, look at the wrong information also and find the same lesion. So the patient had a heminephrectomy, and she had no problem. This is a tampon, and the problem we have often when we do exam is you say, do this, do this, do this, do this. And the patient, you know, she's a bit disoriented, and she don't listen well to the instruction, and she just doesn't follow them. This is an exam done at 3 o'clock in the morning on the weekend, and the resident is tired, he doesn't want to go and look at the patient. He just put the transducer, oh, say, she's bleeding and cramping, this is a miscarriage. Mistake. If we do the transvaginal examination the next day morning, the baby is there. So don't do incomplete exam. This is another interesting one. This is the wife of a big physician in the hospital, and she doesn't want to go through the line and the whole thing, and she just wants to know the sex of the baby. She doesn't want to have the whole exam, just know the sex of the baby. So she comes to me 11:55 when we were going for lunch, and she asks for the sex of the baby. It's a boy. And look at the kidney. Well, if you don't report that this baby has some renal obstruction, you are not doing this patient a favor at all. You're actually endangering this baby. So don't make incomplete exam, do the whole exam. This is a transvaginal examination on a patient that is bleeding and cramping, suspicion of miscarriage, and we don't see anything in the uterus. So it looks like a complete abortion. And then we do a transabdominal scan. You know, we do transvaginal all the time, but we did not used to do transabdominal anymore. And then here, you have a normal pregnancy. So what we were seeing was actually not the uterus, was just a previa fibroid, and that's how we made the mistake. This is a patient that is very modest. You know, those kind of women that give you just a tiny amount of skin and you have to angle the transducer up and down to see everything around. And I thought behind the head there was something here, but I say, no, we have to do transvaginal. And she doesn't want, so we have to negotiate for like 5 minutes, and she does have a large cyst. So try to be gentle with patients that have modesty issue, but you have to do the complete exam anyway. This is a bladder that is too full. It looks like a previa. When you empty the bladder, the placenta is not in correct position. Now, in the old days, 15 years ago, every patient came with a full bladder for ultrasound. So the nurses and the receptionists know, oh, Mrs. Smith goes for an ultrasound, so she needs to drink 3 cups of water. Well, when she comes with 3 cups of water, she has fluid everywhere in her bowels, and this was a suspicion of ectopic pregnancy. How can I find an ectopic pregnancy? You have to wait for all the fluid to go out, so be careful to have the right preparation. Here's an artifact with some shadow in the middle. What are the shadow from? Anyone? Belly button ring. I don't know if Egyptian women put this on, but American women like to have that. And this is actually very bad for the transducer, because if you pass a transducer over that, the little diamonds or fake diamonds can cut the membrane of the transducer. So don't let them keep those. Infertility patient, she comes for an ultrasound, and we do the ultrasound supine, and we can't find the baby. So we turn the patient, and in prone position you can see the embryo. Sometimes change the patient from supine to prone makes a difference. Here's another example. This looks like a cyst or a bladder, and when we turn the patient around, completely disappear. This was just free fluid that was seen in an unusual position. Same thing when you see a fluid interface like this. Normally you think of a dermoid, and you have to think about the patient standing, and when the patient is standing, you can see that this was a fluid interface. This is a problem you may not have in Egypt, but in America we have a lot of very fat people, much more fat than me, I can promise you that. This is a 17-week, and at 20 centimeters, we are still in the fat. So we can't see her from above, we can't see her for the transvaginal. So the solution for these people is to scan from upside down, the patient standing, and then the baby gravitate down, and then you can see some of it. Not a good exam, but this is a way to do it. Another example here, a patient sonographer tell me, I can't see the baby. I said, well, how old is the baby? The baby is 35 weeks old. How can you not see the baby at 35 weeks? Because so much polyhydramnios that the baby is behind the far field zone and you can't see it. So same thing here, you see a very large abdomen and you couldn't see the baby. So what do? You turn the patient around and you scan in knee chest position, and in knee chest position then the baby comes underneath and all of a sudden you can see it again. Sometimes you have difficult patients not because of the anatomy, but because of the mental issue. This is a 54-year-old woman, postmenopausal, who had been to her church, and her prophet told her that she was pregnant. Her husband had a vasectomy 15 years ago, so the odds that she was pregnant was very small. And she was very unhappy when we told her, no, we can't find any pregnancy. So sometimes the mental attitude of the patient is important to take care too. This is a patient I was doing an amniocentesis, and I had just inserted the needle to start crying and moving everywhere. And this is a patient that had panic anxiety, panic attack, and she had been off medication for her panic attack for the pregnancy, and I did not know about that, so I had to pull her needle very rapidly, otherwise it could have lacerated the baby. This is a patient from West Africa, and she had a fibroid, very common. But for her it was a big issue because in her region of the world, women who cannot get pregnant may be divorced very easily, and so learning that she had a fibroid was a very traumatic event, and so we had to take care of this side problems. We have a lecture during lunch on dextrocardia, and the first pregnancy that my resident looked at after the lunch, he said, look, the heart is on one side, the stomach is on the other side. Stomach is there, heart is there. I rescanned, everything in place. How did that happen? Because he took some oblique image and he was trying to only take a picture that looked like a dextrocardia. So be careful about being objective when you do your examinations. Trying to disprove the condition is the same kind of problem. Here is an examination in which the patient comes for a sonohystery, and her exam looked rather normal. And the question is, why would you do a sonohystery for pelvic pain in a woman? And actually, the issue was that she had, not visible on the plain exam, but visible afterwards, she had polyp. So the reason for the exam was appropriate. Here, it looks like there is a single umbilical artery. If you take the correct image, you can see both umbilical arteries, so be careful about the image. This is another terrible mistake that I did. This patient has had 3 miscarriages. She came for bleeding and cramping. We look at the images here, and the baby should be 12 weeks, and that's all we find. So I said, ma'am, I'm sorry, this is probably another miscarriage. There was something happening in the hospital. I had to go to that meeting, and so I let her go. The referring physician, because of that, gave her a DNC, and then in the follow-up, the beta ECG, instead of going down, keeps going up. And this is a few weeks later, there was a normal baby. That baby survived me and survived the DNC. Very good baby. What happened there is I had listened to the history, but I had not asked her personally, when was your last menstrual period? Do you have regular period, anything like that? Then I could have seen that actually her menstrual history was not regular, and this was the source of the mistake. A few anatomical variants. This is a philosopher that I like very much. Snoopy says anything can look like anything else, and vice versa, and I think very true in ultrasound. So some gynecological artifact. So is this loops of bowel or is this a dermoid? Sometimes dermoid can really look like loop of bowel, so be careful about them. Here, this is postmenopausal bleeding, and we find an endometrial lining of almost 13 millimeters. Very abnormal. She goes for biopsy. Biopsy reports atrophic endometrium. So what happened here, this was just a fibroid shadowing over here, another shadow over there, and in between was just a normal texture. We had just measured completely the wrong thing and did not have that patient at all. Bladder. Who says this is a bladder? Who says this is a cyst? Bladder? Cyst? You guys are shy. So we do post-void 2, post-catheterization. So this was definitely not a bladder, this was a cyst. This is one for which I have no answer. We reported this as being a possible cystadenoma. This was large, about 13, 15 centimeters. Our patient is planning to go to surgery. We do an exam just before her surgery. This has completely disappeared. Nothing was left in her pelvis. I don't know the answer to that one. This is a patient that has pelvic pain, and we can't find a reason for that. We find this ill-defined mass, and so we suggest a rescan a month later. She actually then tells us she has a ventricular peritoneal shunt, and this is the end of the shunt that has a fluid connection associated to it. A first few trimester artifact, ectopic pregnancy. You can have all sorts of ectopic pregnancy. Here, this is the pregnancy inside the uterus. Looks normal, but if you look at this one behind here, you see there's a small gestational sac, small yolk sac, and even small activity. So this is a heterotopic pregnancy. keep in mind the possibility of a heterotopic pregnancy. It depends on the population. The numbers often given are 1 in 7,000 to 1 in 30,000, but actually I think it's more common than that. This is not an ectopic pregnancy, this is a loop of bowel, and this is another loop of bowel, so many things can look like ectopic pregnancy. This here, you can see a little sac inside the uterus, but there's a mass on the side that has a ring of fire. The patient is very suspicious for an ectopic pregnancy. She has pelvic pain, so we suggest to do a beta HCG, a repeat beta HCG, and it rises by only 25%. So that's not sufficient. The patient gets methotrexate, and a week later we rescan, and now she is a live fetus. So what we saw was a hemorrhagic corpus cyst, and then she gets another methotrexate, and the baby died. So be very careful. Be very careful with methotrexate in early pregnancy. You have to really be sure. You have to really be sure that this is an ectopic pregnancy before you go ahead. This is a patient that has blood in Morrison's pouch, and it looks like an ectopic pregnancy here. It's actually an ectopic pregnancy on the other index. This looks like a miscarriage, and I tell the patient, with bleeding and cramping, this is probably a miscarriage, and she's very surprised. She looked at me, and then she get up on the table, and I realized she's way postmenopausal. This is a fibroid that is degenerating. This is a patient in which you see a very large gestation sac and a small embryo. Usually these don't have much good prognosis, so we ask her to come back in 2 weeks. She doesn't come back, but she comes back 16 weeks to see this was actually a normal pregnancy. Let me go now to, I don't have my menu here. I was going to show you the end here to finish. Okay, this is a common problem. These are cellular views. This baby has spina bifida, and there's a cellular views, and they don't show the spina bifida at all. And the reason for that is go for a posterior lamina and a vertebral body instead of being coronal like this. So another example, same thing. The issue here is the section doesn't go for the right plane. It goes in between two processus spinosa. So make sure that you have skin covering over there. Let me skip. Boy or girl? Looks like a little girl, but actually is a boy. You see the scrotum is above the leg, so this is a common mistake we have too. This baby here has 7 finger on one hand, so I look at the other hand to see if there's polydactyly 7 finger also. So I look at the toes to see the number of toes, normal toes. I look at the ribs to see short ribs, and actually this is what was happening. The baby was weaving his finger together and giving the impression of polydactyly. A few legal problems. Failure to perform an examination is a common source of legal problem. I don't know how the story is in Egypt, whether you have lots of legal problems or not, but in the US we have. An inadequate examination or incomplete examination. Never do an incomplete examination. Always spend the time. Invented lesions, I have shown you quite a few of these. Complication from procedure is not a problem. Failure to communicate the result. You find an ectopic pregnancy, and the report is typed over the weekend, and the doctor received this on Monday. Well, by the time the patient has had time to die, so be careful that you communicate very rapidly. The rules that we have now in our practice is every report has to leave the practice within 20 minutes of the exam being finished. Effective communication, your function is not to judge the patient. So if you have a patient that look very different from you, different from your values, it doesn't matter. You just have to do the exam and provide the answer to the patient and her referring physician. Do not hesitate when you have a patient to repeat until you're sure they understand. And if you talk with medical jargon, like the baby has IUGR and things like this, the patient don't understand that. You have to explain this in words that are appropriate for their communication level, and take the time to listen, because if your patient doesn't have the time to express her problem, she may never express it and then gets home frustrated and causes a lot of complications. So this is the time of the examination where it's well worth listening to the patient to make sure she's doing fine. So I always finish my examination by asking them, is there anything else I can do for you? So I'm not the one saying, okay, bye Mrs. So-and-so. It is the patient that says, okay, now I'm fine, I can go home, I'll go back to where I am. And actually, I give my card that has my home phone number and my email to the patient. So if they have a record of who they talked to, and if they have questions, they can call me. And it's very rare the patient abuses that. When you make a mistake, inform your risk management team, review what went wrong so it doesn't happen again. And everyone makes mistakes. What is not acceptable is to make the mistake several times. And my grandmother used to say, a good donkey doesn't stumble twice on the same stone. And here in Egypt you have a lot of good donkeys, so I'm sure that you know the rule. And then I wanted to show you this picture here. This is a picture from Samuel Field days. This is called The Doctor. And this dates from 1890. You know, in 1890, what did they have? Of course, no ultrasound, no IV, no antibiotics, nothing. They had absolutely nothing. And so here's a family where you can see the little child over here, the parents are there behind. Why would they ask for a physician to come over there? What could the physician possibly do in those days? Well, I think that what the physician could do was provide moral support and empathy. And I think this is such an important thing, and we have a tendency to lose this with our technology. I'm a very technological guy. I have all sorts of buttons on my machine, but the buttons are really not important compared to the interaction with the patient. The time to listen, trying to see what's going on in the patient's mind, I think that is the most important. The technology is 1%, and the human interaction, I think, is 90%. So, how to avoid making errors? Very simple. You avoid errors by using good judgment. Good judgment comes from experience, and experience comes from poor judgment. Thank you very much.
Thank you, Professor. Now we will have Professor Dr. Mohamed Kamal from Fetal Medicine Unit in Chance.
If you don't mind.
I'd like to start by a question for you, and I want to answer this question. Why we do 3D and 4D ultrasound? To get nice photo or to get anatomical data? What's your opinion? Both, yes. The contents of this lecture will be short review of 3D and 4D to understand the technique and software tips. The objective، أهم حاجة إحنا ليه بنقول المحاضرة ديت؟ Understanding the function of each software to determine حاجة مهمة قوي what do you need in your practice. عشان حضرتك لما تيجي تشتري جهاز 3D أو 4D مش أي سوفت وير أنت هتحتاجه. فلازم تبقى أنت عارف كل سوفت وير إيه الفانكشن بتاعه عشان بناء عليه تختار وتدفع إيه. 3D, we use mechanically moved transducer, which is convex or transvaginal ultrasound. The probe itself includes mechanical planes, sagittal planes, and transverse planes. These three planes, the probe make and give you these planes in perpendicular to each other, as you see, coronal, sagittal, and transverse. And after that, these three planes present in the image, in the monitor. This is a sagittal plane, transverse, and coronal. And this is one of the advantages of 3D ultrasound, to get the three planes in the same time and you can analyze the image. And after that, the machine reconstructs the 3 planes and give you this rendering mode. This is the 3D image. What about 4D? 4D is a continuous 3D scanning. Special transducer that work continuous 3D and give you this image. So 3D is a photo, while 4D is video. Okay? And after that, by 4D ultrasound, you can get lifelike images like this. We have multiple rendering mode, but the most common rendering mode we used was called surface mode, maximum mode, and minimum mode. The surface mode used for clear visualization of fetal surface. If you want to examine fetal surface, use this surface mode. Maximum mode reduces the echogenicity of soft tissue, so you can examine the bone by maximum mode. The last one, minimum mode, is used for internal organs. Now we want to start to talk about the software. What are the softwares present in 3D and 4D? We have a lot of software. I will explain each one and what is the benefit of this software. But at first you should know software has different names according to the company. Like the first one, in Mindray, it's called Smart Follicle. Other company called Sono AVC Follicle. So we have different names for each software. The first one, what's called Smart Follicle or Sono AVC Follicle. In an infertile patient, when we use induction for ovulation, we will get large number of follicles. But sometimes we face problems to calculate these follicles, to detect the main diameter of the follicle and the volume. So this software designed to automatically calculate the number of the follicle, the main diameter of the follicle, the volume of the follicle. As you see, each follicle, the software automatically can trace and can give special color for each follicle. So it will be easy for you to follow up during folliculometry. And after that, the software will list these follicles in a table according to the size. Red one is the biggest follicle, its volume will be 4.2 and the main diameter 3.1. The second one is green, which is volume 2.1 and diameter 1.7, and so on. So it's easy for you to calculate the number of follicles, the main diameter of the follicle and volume, and you can follow up these follicles through this table. The second one called Smart V or Vocal. As we know, it's difficult for us to measure the volume of any irregular structure. This software helps you to obtain accurate volume measurement for any structure which is irregular outline, like fetal lung, like kidneys, and so on, endometrial cavity. How come? If you want to measure the lung volume, what can you do? If we want to measure the volume of this, what do you need? Take volume 3D for this, and after that, you trace the edge of the organ. After that, ask the machine to rotate for 30 degrees or 15 degrees, as you like, and trace another line around the edge. After that, rotate and trace another line around the edge, and so on. After that, the machine itself will calculate the actual volume of the organ, like lung, like this mass, or like the endometrial cavity. Another software called iPage. The idea of iPage, it looks like CT and MRI. You take a volume of the organ, and after that, the machine automatic give you parallel slice, and you can analyze this slice as you like, the distance between the slices, 3 millimeter, 5 millimeter, and so on. You give this software give you multiple slices, volume in one display, and you can simply analyze these acquired volumes. Another software called Sono NT. This software used for nuchal translucency measurement. As you know, nuchal translucency measurement is one of the important screening for chromosomal abnormalities in the first trimester, in the period between week 11 to week 13 plus 6 days. And the problem, it is operator dependent. This SonoNT is automated tool to measure nuchal translucency to reduce operator variability. How come? You just adjust the fetal position, and after that you can put yellow box in the region of interest, and the software automatically trace red line in the inner surface of the nuchal area, and after that this software will measure the distance between these two lines and give you the widest distance. So by this software we can reduce the operator variability. Slice contrast view or volume contrast imaging. This software designed to give you a good resolution and contrast and reduce noise. How? We take 3D with thick tissue. We need thickness to give you more clear view. Like this. You can adjust 5 mm thickness or 10 millimeter as you like. This occurs by filling up the gaps with tissue information from the adjacent layer. So this will reduce the noise. Another problem we use in 3D straight line. Straight line sometimes will be difficult for you to assess like cervix and endometrium in AVF or RVF uterus. Or if the fetus is bending, sometimes you can assess the fetal spine from up to down. So another software called Slice Contrast View Plus or OmniView, this line is curved line with slice thickness, so you can assess the upper end of the spine and the lower end in the same time. And also in the endometrium, you can assess the fundal of the endometrial cavity and the cervix in the same view. Another software called SonoVCAT Heart. This software automated tool to help you to examine fetal heart anatomy in different planes by one only volume acquisition. It means you should adjust for chamber view and take 3D volume only. After that, this software will give you 6 cardiac planes in the same time to assess the cardiac in these different planes. The first one give you left outflow tract. The second, right outflow tract. The third, stomach. The fourth, venous return, ductal arch and aortic arch. So you adjust for chamber view, take 3D volume, and by this software you can get these 6 planes at the same time and you can assess. So it is time consuming. Another software for the fetal echo, one's called STEC. STEC like SonoVCAT but by 4D. You can analyze structure and function analysis of the heart easily. One of the recent software what's called iLife or high definition. iLife is a software enable you to get realistic view of the fetus with human skin like, as you see. This software depends on 6 movable light source, and you can adjust the direction of light to get suitable image like this. This is a 4D of iLife. The last software is UltraView and 4D View. It is one of the important software in 3D and 4D. It is for post-processing software. What's mean post-processing? You can transfer all the data from the machine to your laptop, and after that you can manipulate on your laptop. You just take multiple volume from the patient and ask her to go home, and after that through your machine, your laptop or PC, you can restore the image, recall, manipulate, and so on, and you can analyze any image. Now, this is what's called 5D. Is there 5D? في حاجة اسمها 5D? What about 5D? .5D is a software. One of the company choose the smart follicle to be 5D follicle, and called Sono NT is a 5D NT, and called Stick 5D hard, and called OmniView 5D CNS, and so on. So there is nothing 5D. We have 3D and real time 4D. 5D is a software only. Okay. Home message 3D and 4D ultrasound should be accepted as natural development of ultrasound imaging technology. 3D and 4D ultrasound are not substitute for 2D ultrasound. 3D and 4D ultrasound are not nice photo. The technique of scanning in 3D has to be learned, as this is different from that in 2D. It is necessary to learn how to use an entirely new software to get their benefits, to deliver the high level of imaging excellence your practice demand. At the end, it's honor to be with Professor Jeanty, one of the pioneers in fetal medicine and our mentor. Thank you for your attention, Mr. Andy, and thank you for Mindray company, Mr. Andy and Mr. Richard. Where Mr. Richard? Mr. Richard and Engineer Ataya. Thank you. Thank you for your attention.
Thank you, Professor. Now we have Dr. Yehia Wafa, Professor from Al-Azhar University.
Jeanty, and after Dr. Kamal Atman, I'm trying to compress the presentation as much as we can in order not to miss the time of the lunch. I'm going to address the presentation under the title of Ultrasound in Infertility and IVF. And now, is the fertility curve is declining? Are we going for a low fertility era? The answer is yes. What is the evidence? The evidence starts with the male that the mean sperm count has dropped from 113 million per ml by 1940 to 66 million per ml by 1990. And if you are going now to the WHO data, we can see that the normal semen analysis count is almost 15 million. So we are going down. When we were students, the mean number or the accepted number was 60, and today we are dealing with 15. The semen volume have dropped from 3.4 milliliters to 2.75 milliliters within 50 years. There is a study done in UK denoting that the 40% of the cases of IVF, we have to, for female indication, we have to treat the male first. We have some problem with the male. And the incidence of hypospadia, cryptorchidism, testicular cancer is rising all over the world. Regarding the female, that we have a social problem, especially in our countries, regarding the advanced age of marriage. And there is a study in USA denoting that primary gravida over 35 has increased by 85% in the last 25 years. There is across the Atlantic or in Europe, there is almost free sexual life, which increases the incidence of STDs and, by the way, the tubal factors. Lastly, the prevalence of PCO has been increased in London area from 17% to 24% over 13 years or 14 years, something like this. If we're going to go deeper, we have to see what's the causes of female infertility. We have to say that we have 40% of ovulatory dysfunction, about 40% of mechanical factor, another 10% for cervical, and 10% for unexplained. Maybe these have changed recently, and the explained gain a lot, and the cervical factor is going down. What is regarding the ovary, I'm going to have it in an anatomical stepwise. We are going to speak about the ovary, then the tubes, and then what's in the IVF. The ovary will have three main categories I'm going to address. That's the PCO, the endometriomas, and ovarian cysts. Regarding the PCO, traditionally PCO is oligohydronuria, obesity, hirsutism, and infertility. And this is the presentation of the PCO, the different presentation, which is obesity, menstrual disturbance, infertility. You can see that's 72%, hyperandrogenism, and it may be asymptomatic. And here is the picture of the normal ovary. This is the follicle, and this is the normal ovary. And how can you diagnose the PCO? You can diagnose PCO number one by the ovarian volume. The ovarian volume is should be more than 10 milliliters, with multiple small irregular arranged subcortical follicles, which is the Nichols appearance, and with dense stroma or echogenic stroma. Those are the diagnostic steps. And it's associated with endometrium like this. This is the triple endometrium, the famous triple endometrium, and this is another proliferative endometrium that you are going to see in the PCO, and this is the secretory endometrium that you will not see it in cases of polycystic ovarian disease. This is a typical picture of PCO in the laparoscopy. To go through the ovarian cysts and endometrioma, actually there is a dilemma for diagnosis of corpus luteum hematoma and endometrioma by ultrasound. You can find some common areas. Regarding the corpus luteum hematoma, you are going to find the spider-like material. I'm going to show you the picture. It may contain irregular shaped blood clots inside, but it's usually regress spontaneously within 4 to 6 months. This is unlike the endometrioma, which is showing the ground glass appearance with solid masses around in the wall, which is wall nodularity, which is seen in from 20 to 35 of cases. And let's go to the picture. This is the ground glass appearance of endometrioma. And this is another endometrioma, which is almost bilateral. And this is another ground glass appearance of endometrioma. And this is the spider shape of the corpus luteum hematoma, and we can find here that's the hematoma, and this is the free fluid of the corpus luteum. And this is a needle inside endometrioma. Before IVF, we are preferring to aspirate it just to be free to do the stimulation. Regarding the tubes, we are going to have a hydrosalpinx, pyosalpinx, paraurethral cysts, and lastly, ultrasound-guided tubal patency, which doesn't gain any popularity in Egypt, but it may be in UK. It is one of the principal investigation for tubal factor. This is our classic reference for assessment of the tube, which is the histopingogram, and this is the fallopian tube with ultrasound. So when the fallopian tube is normally not visualized by ultrasound. There are three characters of the tubal mass. One of them is regular sausage shape appearance of the tube. Number two is this is incomplete septa, that represents the mucosal folds. Number three, that is the cogwheel appearance. We can see here the mucus this like a cog wall, they tears. This is one of the, and this is pathognomonic for tubal masses. When you see it, definitely this is tubal mass. And this is the sausage appearance, and this is the glycosal pores are inside. And this is the ultrasound guided tubal patency test, which is known as HICUSI. The HICUSI, you are injecting a hyperechogenic material inside the uterine cavity, and you can follow it while it is going to the tube. And we have tried to do it in the university, but actually it was very expensive because single kits were costing around 58 sterling pounds. Okay, so it is cheaper to do it through histangiogram. Lastly, I'm going to speak about the uterus. The uterus, we are going to speak about the myomas, congenital anomalies, endometrial lesion, and Asherman syndrome. Let's say that visualization of uterine cavity, our golden standard is the hysteroscopy, but saline enhanced sonohysterography is adding a lot. This is the study of the uterine cavity using the 3D, and we have Google. This is another 3D machine, LCD image, and this is the detection of congenital anomalies. Actually, we don't need to do a lot of laparoscopies now for diagnosis of congenital anomalies of the uterus in the presence of this modality of investigation. And this is another unicornate uterus, which is as clear as histangiogram. And this is uterus diadelphys by laparoscopy. And now to go through saline enhanced sonohysterography, you can see this is the normal what we are going to find. This is quite clear and smooth uterine cavity. It's done during the proliferative phase. And this is 2D. This is the order in 2D before injection. This is what we thought that it is a hyperechoic area, and that's after sonohysterography. It's very clear what's there inside the uterine cavity. And some debris inside. Then what happened after injection, that we can see that there is a polyp inside, and we have detected a formula that if this angle is acute, so you can do it through hysteroscopy. If it is obtuse, so it means that a big part of the fibroid is inside the uterine muscles, so you cannot go by hysteroscopy. So another echogenic area in the endometrium, and after injection, what has happened is fibroid polyp. This is the Asherman syndrome, and we have a lot of work with Asherman syndrome. You can see a regular interrupted echogenic endometrium. What's important is that when you are trying to inflate the cavity with sonohysterography, there is failure of distension of the uterine cavity. Regarding the IVF, what's important is the monitoring of ovulation, ultrasound-guided ovum pickup, follow-up of case of hyperstimulation, ultrasound-guided embryo transfer, diagnosis and follow-up of pregnancy, and lastly, ultrasound-guided embryo reduction. Regarding the monitor of ovulation, the goal is to achieve good number of mature oocytes to avoid hyperstimulation. Don't miss the preliminary scan, which should be done during the luteal phase. In order to avoid measuring a retention cyst during the follicular phase, we are usually starting monitoring from 6 to 7 days after stimulation. And when you are reaching to at least 3 follicles with mean follicular diameter from 18 to 20, you have to trigger your ovulation. This is the stimulated ovaries. That's what you're going to see just on the day of HCG. All of these are follicles. I'm sorry. Then we do ultrasound-guided transvaginal ovum pickup. This is just a needle inserted in the probe going through the phronesis to collect the fluid inside the follicle, which contains the oocyte. And this is the ovary after the injection. What we are going to follow up in hyperstimulation, we are going to follow up the ovarian size, corpus luteum size, the volume of the athletic fluid, and if there is any hydrothorax or hydropericardium. Ultrasound guided embryo transfer, that's ultrasound guided embryo transfer. Actually, it is according to the claim, it improves the results. If you are going to do a transabdominal ultrasound, when you are going to transfer your embryos, you are getting a better results. There was a debate, but I think that we got a conclusion now. That is what are we doing before, that you are going to know your track, and you are going to adjust the caster according to this line. At the same time, you are going to see the caster white it is inside the uterus, and you are going to see the embryos which are here. Regarding ultrasound guided embryo reduction, the embryos technique is to reduce the number into 2 or 1 embryo. There are some rules which we are adopting for selection. Actually, we are usually exclusion the sacs which are behind the mean. If you have 5 sacs, so we are going to keep 2. We are going to keep 2 with mean sac diameter and crown lump in the middle, not the biggest one and not the smallest one. If we are having all with the mean follicular mean sac diameter and mean crown lump, so we are going to choose what is near for the needle itself. If all are the same distance with the needle, we are going to select the higher embryo. We are using single lumen needle. We are either aspirating the embryo itself or injecting potassium chloride inside his heart.